Thanks a lot, David. It's a great pleasure to be here, and I would like to thank the organizers for inviting me to contribute to this session. I think we've been talking a lot about extended half-life products and managing a patient's expectations. But since I'm a physician, I also quite like to put in bracket physician expectations, because at least in Europe, where there isn't any direct marketing, the patient expectations are somewhat driven by our physician expectations. These are my disclosures. I think before we kind of move on in terms of where we are, in terms of the expectations, it's always helpful to kind of look at where we are now. I think I always like to kind of remind myself of the progress made, especially when I'm very frustrated with some of the bureaucracy in the NHS. I kind of look at these slides and say, we've made a huge difference for patients with hemophilia. In 1920, a child would not have survived beyond the first 10 years. But over a period of 100 years, we are kind of now, most patients in developed countries can expect to see a normal kind of a life expectancy. Again, I think we kind of need to anchor all of our management practices in these two kind of, the aim and goal of hemophilia as kind of, I think has been written about on multiple occasions. I think our aim is always to ensure that we meet the unique treatment needs of a patient, and not just about health in terms of physical, emotional, and psychological health, but we are also very keen on their emotional, social integration, and we want to facilitate their educational achievement so that they are kind of contribute to the society. And again, our goals are we want to decrease the morbidity and mortality, and again, as we mentioned, we want the patient to be a fully and active participating member of the society. I think keeping these kinds of aims and goals in place, it's quite then easy to kind of think, well, what are the outcomes we want for our patients? I think currently, replacement therapy and prophylaxis are the standard of care. And I think as David and my colleagues have kind of explained, the major things we want to achieve for this is we want no bleeding. It's not just in joints to prevent joint damage. We're also interested in prevention of fatal bleeds. Remember, fatal bleeds was the most common cause of death about 70 to 80 years ago. This is a benefit that you do see with prophylaxis, although it's not often mentioned. You want to decrease the number of hospital admissions. We want patients to be far away from hospital. And again, I think in all of this translates into improved quality of life. We want treatment that is safe. I think we don't want to repeat our history in terms of infections. Again, inhibitors is a major issue. We kind of try what we can do to decrease the incidence and inhibitors. And definitely we are kind of unkeen to have any kind of thrombotic events secondary to treatment. We tend to individualize treatment. I think this kind of individualization is done at both trough levels and frequency, but we also need to look at the patient factors. I think we take into account the patient lifestyle, the prevalence of joint damage, and also the cost of treatment. So if I think access and cost is an issue, you probably would not have the same higher trough levels that you might want to aspire for in some of the countries currently. So in terms of the current challenges that we have in hemophilia treatment, I kind of tend to look at them into various domains. In terms of environment or social issues, access to treatment is an ongoing issue. I think cost of treatment is a major issue, not just in developing countries, but also in developed countries. I think we're increasingly, even in the UK and I think across the US, we're being challenged on the amount of cost per patient per year. And we have to constantly provide justification. So cost of treatment is a universal issue. It's not limited to one part of the world. Provision of comprehensive care, again, is a major issue because, again, this is a living, breathing infrastructure. I think trained staff increasingly, I think we have to kind of develop them and hold on to them in terms of hemophilia care. I think with regards to the disease, inhibitors, especially in hemophilia A, there's a lifetime cumulative risk of inhibitor development. That's something that is a major challenge for us. And with regards to patients, venous access, I think this is a major issue in both ends of life. I think in terms of children and adults as well. Patient compliance and adult prophylaxis. And I think compliance is very much driven by the frequency and the burden of illness. And also, we also have a big issue of variability in physician practices, not just across the world, but within the same country. So if we kind of, in addition to the challenges, there are a lot of unmet needs. We have the burden of illness. I think we have patients who have got joint damage, and then there's joint damage that progresses despite prophylaxis. We have burden of treatment. I think the frequency of infusion tends to drive the compliance and the burden of treatment. There's some amount of restriction to normal activities with potential for exclusion. This is particularly a problem in young children. We have treatment schedules that are restrictive. I'm not particularly fond of alternate day regimen which says you have to take a infusion at 8 o'clock every alternate day, because more often than not patients say yes, they're doing it, but then they go away and then actually they're finding it quite difficult. So I think you can't have regimens that are too restrictive. We are also treating patients with the lowest effective dose. So essentially the protection window or prophylaxis window are quite narrow. If the patient has got a delayed dose or a missed dose, then we are kind of seeing the consequences. So you lose a year's worth of effort. You've put in an effort and made sure that the patient hasn't had a bleed. But because the narrow protection windows, essentially you kind of then have a couple of bleeds and then you've lost all of your work for the last many years. But there's also a bit of an issue in terms of we are not completely, we don't have consensus on what is the ideal prophylactic regimen, how to initiate prophylaxis, how are we going to escalate prophylaxis, what are we going to do in terms of investigations for treatment failures. And then we also have a bigger problem in terms of we haven't agreed in terms of what are the outcomes for good prophylaxis. So we can't kind of compare and say this patient is being treated better than this patient, because we kind of put it as individualized treatment. And as I've mentioned, in terms of joint disease progression is an ongoing issue. In this context, I think I think there's a lot of excitement, and I think that is probably the one word that has been mentioned at many sessions in terms of it's an exciting time to be in hemophilia. And I think what are the expanding possibilities that make this to be a very exciting time? I think in terms of therapeutic options, I think the one thing my kind of brain kind of goes into a bit of a buzz and a shutdown because there are so many choices. And I'm kind of thinking, what am I going to do? In terms of extended half-life factors, we have Elocta, Adenovite, Alprolix, and Indelvion. They're all licensed. We also have the pegylated N8GP and the N9GP that will be licensed in the next 12 to 18 months. We have Bayer pegylated factor VIII, which I also assume will be licensed in the next year or so. And then we have in trials albumin fusion 7A and the CT fusion 7A. Then we have a few small molecules coming through. I think you can kind of divide them into two classes of agents. The first is the factor VIIIa mimetic, called as emicizumab, and then we have the inhibitors of inhibitors, which include consuzumab and fitusiran. And then we have about a huge number of players doing gene therapy. We include Bayer, Baxalta, BioMarin, Pfizer, and Unicure. So in terms of the kind of choices that are available, we kind of have to think, how are we going to treat our patients? I kind of want to suggest that there is a paradigm shift in hemophilia care. And this paradigm shift has been kind of pushed by the extended half-life factors, but is going to be taken further by the small molecules and also by gene therapy. If we kind of look in terms of what is the paradigm shift, why do I think there is? I think there are two major domains in the hemophilia management where it is driving at. The first is the outcomes, and the second is in terms of treatment. If you look at the outcomes, I think there's a huge discussion, I think, over the last couple of years in terms of what should our new outcomes be. I think there has been a general, I think there's been a big push to kind of move out of the old outcomes because there has been a general acceptance that the old outcomes were related to just enough treatment but not optimal treatment. So if we do optimal prophylaxis and optimal treatment, how should outcomes look like? Are we going to say a zero ABR is the ultimate outcome? That may be acceptable in small children, but it may be quite difficult in patients with advanced joint disease. How are we going to kind of look at burden of illness? Because we don't truly have an outcome measure that looks at burden of illness. Quality of life, I think there are multiple tools that are used, but again, I think none of them have been found to be very sensitive when they have been trialed in extended half-life factors trials. We're also interested in terms of the convenience and burden of treatment. How does this translate into compliance? How does this translate into patient satisfaction? I think there has been a general push that we should try for a mild phenotype rather than a moderate phenotype. Traditionally, we've said if we come to 1 to 2%, we are very happy, and now there's a general push. Is it 5, 10, 15? I think you can pluck a number, and then you probably would say, yes, we can get there. I think we're also interested in terms of a product which has got low risk of inhibitors, a product that actually kind of can be used with trauma and surgical bleeding. Again, I think we can't ever abandon risk of infections. We're also, I think, in terms of talking about no thrombosis, and also interested in terms of is it possible to have products without any monitoring. And I'm sure over the next couple of years we will think of more outcomes that we think reflect this paradigm shift in our care. In terms of hemophilia treatment, what is the paradigm shift? I think over the last many years, the major focus has been in terms of replacing the missing factor. We've also been interested in gene therapy or replacing the missing factor, missing gene. But in the last couple of years, there has been a kind of an interest in terms of why don't we just look at restoring thrombin generation? Why is restoration of thrombin generation an attractive option and a paradigm shift? Essentially, thrombin is your final common enzyme of your coagulation cascade. And if you generate enough thrombin, you are able to form a clot. There's a lot of redundancy between the various pathways in terms of platelets, thrombin, and fibrinogen. And I think there's been a lot of interest in terms of exploiting these pathways and saying, yes, by exploiting some of the existing pathways, we are able to restore thrombin generation. In terms of restoration of thrombin generation, it's not a new concept for us. I think we are using it already in terms of when we are overdriving existing pathways. So you have NOVO7 and FIBA. They are bypass agents, but essentially what they are doing is restoration of thrombin generation. I think we have the mimetics, which includes, as I've mentioned, the factor VIIIa mimetic. And then we have a rebalance of coagulation through loss of inhibition. And the two inhibitors that are being inhibited in various studies are the tissue factor pathway inhibitor and also antithrombin. So I'm just going to kind of just go through a few of highlights in terms of restoration of thrombin generation. I think there's a lot of, late-breaking abstracts and presentations on some of the molecules that I'm presenting over the next few slides. So to me, it is just, I would call it as the next generation of molecules. It represents a biotechnology coming of age because it's essentially precision engineering. You're kind of learning how coagulation works, and then you're targeting an aspect of coagulation. We are exploiting our understanding of hemophilia and normal coagulation, but I suppose the excitement is to do with the fact that they can be administered subcutaneously. The first one is I think the first one that has been the data has been published is the factor VIIIa mimetic. Essentially, it is what we call as a bispecific antibody. It binds the it binds in 9A on one aspect and then 10 on another aspect. What does the bispecific antibody do? I think normally in normal coagulation, factor VIII, which is a cofactor, bridges factor 10 and 9A and results in the generation of 10A. And essentially, in this, the factor VIII mimetic, MSCC-MAB essentially does this function and results in the generation of 10A. And this 10A then results in a clot formation. So there's been a study published in NEJM about a month, I think earlier this year. I think this was 18 Japanese patients with severe hemophilia A were enrolled into the study. They had weekly injection of emicizumab for 12 weeks at 3 different doses. Whilst the main endpoints were safety, where there were no serious adverse events, they also looked at the pharmacokinetic parameters, which essentially showed a dose-dependent increase in the drug concentration. They also looked at pharmacodynamic profile, which was essentially the one they chose was activated partial thromboplastin time, and this was shortened. They had an exploratory endpoint, which was the annualized bleeding rate. Probably the endpoint of interest to us and the endpoint that will be measured in the phase 3 pivotal studies. And what they essentially showed is that there was a decrease in bleeding, and the highest effect was seen in cohort 3, which was essentially 3 milligram per kilogram of emicizumab. In this, the median ABR changed from 15 to 0. This is a small number of patients, but essentially suggesting that it does work, and we will need to wait for the results of the phase 3. If we go on to the other inhibitor, which is the concizumab, or which is an antibody against the tissue factor pathway inhibitor, this essentially blocks your initiation pathway. So this is your normal initiation pathway where you have a 7ATF complex generating 10A and 9A. And this is the tissue factor pathway inhibitor which is blocking this complex. By giving a concizumab, you're essentially removing this lid or the inhibition, and then you're allowing the entire coagulation to be driven through the extrinsic and common pathway. And in terms of the preclinical studies, what they have shown is that in a rabbit model with hemophilia, when concizumab was given, the bleeding had come back to normal. So this is a normal amount of blood loss. This was when the hemophilia was induced in the rabbit, and when they gave the monoclonal antibody at increasing concentration, there was a decreasing amount of blood loss. And simultaneously, they've shown that there was an increasing amount of thrombin generation when the antibody was added to plasma. So in this one, there was a phase 1 study that was conducted, which was essentially a safety study, and they were looking at changes to coagulation to suggest that the antibody does actually work. What they've shown is that when the antibody was given, the free tissue factor pathway inhibitor, the amount of protein just decreased to baseline. I mean, it was undetectable. And this was associated with an increase in D-dimers, suggesting that the coagulation was being activated and the thrombin generation was being restored. This was, again, I think, an exploratory analysis where they looked at the relationship between the bleeds and the amount of the tissue factor pathway protein. And I think what you can see is that with increasing concentration of the antibody, there is no detectable tissue factor pathway inhibitor protein, and the bleeds are essentially there are no bleeds at this end of the spectrum. And there is one bleed which was actually a traumatic bleed. And the last one that is actually, and the last drug, which is a small molecule, which is an inhibitor of an inhibitor, is fituran or ALN83. What this does is it exploits a natural pathway for gene silencing, and the natural RNA interference mechanism, it's a mechanism which is normally present in the cell for regulation of protein synthesis. And what Alnylam have done is they've created what they've said is a small interfering RNA therapeutic agent that targets antithrombin secretion. So the amount of antithrombin protein that is being produced is decreased when you give fituran. So these are the interim fituran results that were presented in November 2015. And essentially what they've shown is this is the thrombin generation in healthy volunteers. And then with decreasing antithrombin or increasing inhibition of antithrombin, the thrombin generation is increased. And essentially in some patients, it goes into the normal range. So I think in summary, what I can say is that our treatment of hemophilia in 5 years' time is going to be very different from our current approaches. I think innovation in therapeutics has presented us with new opportunities in the form of extended half-life concentrates, but there are more to come in terms of the small molecules and the gene therapy. But I think what is very critical is that as a community, we need to exploit these new opportunities and translate them into improved outcomes. Because improved outcomes is just not about treatment, it is about pathways, and it is about understanding what is it that is actually feasible. And I think it's always important to remember that with new challenges, I think some of the new opportunities come with new challenges. One particular challenge would be does the loss of regulation of normal coagulation mean? Does that translate into excess thrombotic risk? And again, we can only answer this in the phase 3 studies. But I think it's also important that we monitor for the known and unknown risks. While the known risk would be thrombosis, we don't truly know what the unknown risks are, and as such, patients need to continue to be monitored. Thank you.